Hello, everyone. I'm Alexis Carmer from the Sugar Science. Today we have the second panel in our series on early detection of T1D. Last week, the panel discussed screening, and today's panel will discuss monitoring of stage 1 and 2 disease. Our expert panel members today include Kimber Simmons from the University of Colorado, Kurt Griffin from Sanford Health in Benaroya, and Jennifer Law from UNC. Welcome, all of you, and thank you for joining us. Our format today will start with presentations reviewing the purposes and strategies for monitoring, followed by descriptions of monitoring for the Ask, Pledge, and Early Check programs. We'll have some time for questions and discussion at the end, but if you have a specific question during one of the presentations, please put it in the chat box. We'll start out now with Kimber Simmons. Hi, Kimber.
Hi, good morning or afternoon, I guess, depending where you're at. So, I get to kick off this session by talking about what the purpose is of following patients or participants, and we call that monitoring. And so, to start off, this is how I like to think of it. When we're talking about following patients with early stage type 1 diabetes, there are many reasons to do that, but the one that is really hard to argue with is that we provide clinical safety for patients if we are following them over time. And I'll show you some data on how we can reduce how sick they are at diagnosis and potentially prepare them for a better course of living with type 1 diabetes. So this is a study showing that in Colorado, where we're from, the rate of DKA or diabetic ketoacidosis at diagnosis. And you can see how over the years it continues to increase. Unfortunately, we are teetering around 50 to 60% most years recently. And a few years ago, we had one of our nurses look at the data to show that if we looked at the over 5,000 children that were diagnosed with type 1 diabetes between 2005 and 2021, and we looked at the children that were not screened compared to those that had been screened through various different research programs, that the rate of DKA dropped from 48.5% down to under 5%. And this translates to the finding that if all children in the community had been screened, that about 90% of DKA could be prevented. But I think what's important to realize here is that it's not just the screening that protects people from arriving at diagnosis and DKA, it's also the follow-up that happens. And so if you look at the black bars, you can see community patients coming in overall, almost 50% with DKA. And then you can see the gray bars in the middle showing that for patients who did not follow up but were screened, so just had the knowledge that they were going to develop type 1 diabetes, their rate of DKA was also lower, less than half percent, less than half the risk if they had just been screened. And then you can see where we can really make the biggest impact is by following or monitoring patients. And that's where we get those DKA rates down to less than 5%. And importantly, the severe DKA, which really sets people up poorly, is close to 1%. And this is always good data to review because it shows that there is potentially a long-term impact for people if they arrive into diabetes with DKA or arrive otherwise healthy. And so you can see these patients that are split up by severity of DKA, with no DKA being the line on the bottom. And you can see that when these patients were followed over time, that A1C was higher in patients who presented in DKA, and specifically in patients who presented in severe DKA, the rate was, over 1% higher of having an A1C over 1% higher. The second reason that's really important to follow these patients is because there needs to be a care pathway structure so that we know when to guide escalation of testing and referrals. And there'll be, speakers that are going next that will talk about what you do in a care pathway. But in order to know what to do and how often to see somebody and what testing should be done, you need to be able to see them and to have very basic information about what their islet autoantibody status is and what their glucose levels look like and whether or not they're having symptoms. And not only does that guide the routine of how often you're doing testing, but also when we're talking about follow-up in a clinical world, this is where it becomes important to understand, are they going to be followed by a general care practitioner? Are they going to be moving towards specialty care? So when do these referrals take place? When do these transitions take place? And without having information from routine follow-up, we can't make those clinical decisions very well. Okay. The third reason that it is important to follow patients with early stage type 1 diabetes is so that they can make active decisions around how they want to be treated for their early stage type 1 diabetes, with the goal potentially of delaying type 1 diabetes clinical onset. In the United States, there's a clinical treatment option with teplizumab, or Tzield is the brand name. And then, of course, there are clinical research trials. And so this slide just kind of shows all the different ways that we could potentially intervene in disease. And this is a slide showing drugs that have been used once patients have already been diagnosed with type 1 diabetes. But the goal really is to start moving these drugs back further while these early stage patients are being monitored and followed, to see that if they have an effect and if we can delay or prevent type 1 diabetes with a combination of these drugs, or doing some unique different designs. And so I think it's important to see that in order to be able to enroll patients in any of these studies where we can block T cells or try to block B cells or decrease the cytokines and inflammation, we have to actually be able to know that those patients exist. And the way that patients can tell when they're being followed, if what studies are available. Breakthrough T1D has a really nice find a clinical trial tool. There's always clinicaltrials.gov, which can be a little bit harder for a patient to navigate. And then pointing out the one drug that is clinically approved, teplizumab, I think is just really important here to see how many clinical trials this drug has been part of, and why it's so important for patients to know about these trials and enroll in these trials so that we can move clinical treatment forward. And so the trial called TN10, a TrialNet trial with teplizumab, is what led to the clinical approval by the FDA in November of 2022. For this drug with the indication to delay the onset of type 1 diabetes. And this is the results from the trial that led to the approval. So the little survival curve is what everyone always sees during talks, and it basically shows that if you're in the red line on the bottom, you have less survival, and the blue line on the top, who received teplizumab, survived longer. But I like to break it down looking at the 3 studies that have really been done, looking at teplizumab treated versus placebo, and what that has looked like at the 3 follow-up periods over time. And I think it's just important to note that although people with teplizumab do progress towards developing type 1 diabetes, at each follow-up point, there's a significantly larger number of people still living without type 1 diabetes. And you can see that. You can see how at the very end of the 6.7-year follow-up, you can see that the percent of people living without type 1 diabetes, being 36%, is higher than the people at the initial 2-year follow-up who received placebo. So there's definitely an effect. And so who can be treated with Tzield? Well, this is why we need to follow patients, because we need to know who has antibodies and who has dysglycemia by the methods that you'll discuss in the following sections. And importantly, this is something that's approved for age 8 and older, but there is an under 8 indication being reviewed by the FDA with a target date of April 29th. So we may have something to actually offer to all patients who present with type 1 diabetes, early stage. And then the last reason that I think is sometimes not thought about, but the way that we got to where we are with all of this stuff is because we followed patients in research studies with early stage type 1 diabetes. And we still need to continue to gain scientific insights and build data sets to better understand progression and be able to personalize care and provide precision medicine. And so right now, our only real biomarker is islet autoantibodies, and the number, the titer, the epitope spread and age are things that we have as our staging backbone and the thing that we understand really well. But in order to be able to add predictive value beyond autoantibody positivity, so we can better anticipate how fast someone will lose beta cells, we need to create more biomarkers that are reproducible and scalable across different sites and different labs. And these need to be integrated really well with clinical signals that we see, such as what are the OGTT results, what do CGM metrics look like, what does C-peptide look like. And so better biomarkers will help us move from just knowing who is at risk to who is progressing, how fast are they progressing, and when should we act with different disease modifying treatments. And so this is a fairly complicated slide, but I think it's just important to say we still have a lot of work that's being done and a lot of great work in this area that's been done by our basic scientist colleagues, looking at how genetic risk scores can impact this, looking at different markers of beta cell stress, such as a proinsulin to C-peptide ratio, doing T cell immunophenotyping, looking at tetramers, and also looking at cytokine profiles. There's work being done to see if we can actually do imaging as biomarkers. People interested in looking at microbiome or environmental gut signatures. And then we have a lot of work trying to integrate all of these things into composite or integrative risk scores that can help us better predict who will develop type 1 diabetes, when, and how to best help these patients. So in summary, routine follow-up is important because it provides clinical safety, mostly by preventing DKA, also gives time for families to learn the information that will keep them safe. It provides structure to enable timely referrals to specialists who can discuss treatment options, and it allows for that shared decision-making around those treatment options that include both clinical treatment, but many clinical trials. And it allows for continued development of understanding the pathogenesis of type 1 diabetes in diverse populations, which is not completely well understood at the moment, and the development of biomarkers to personalize risk assessment and treatment.
Thanks, Kimber. I think next, Brigitte, you're up next, and she's going to discuss strategies for monitoring.
Great. I'm going to talk a little bit about autoimmunity screening for kids, which is a screening program we have ongoing here at the Barbara Davis Center. We've screened over 40,000 kids and are continuing to monitor it. But mostly I'm going to be talking about different ways to monitor and how they're not all created equal. So the ASK protocol, we screen at multiple sites, identify children who are multiple islet autoantibody positive or single, and then are invited to the Barbara Davis Center or for confirmation, or that can be done remotely. For those who are persistently positive, children who are multiple or single high affinity, meaning that they have both RBA and ECL, two different assays that we use, discussed a little bit last week. Those are invited for monitoring, and they are seen every 3 to 6 months, depending on their risk. That includes both age and antibody positivity. And Kurt Griffin's going to be talking a little bit more about the tempo of monitoring, so I'm not going to get into that. But we use A1C, CGM, and oral glucose tolerance testing with the goal of preventing DK and eventually diabetes, and other goals as well that Kimber Simmons just so wonderfully outlined. So let's talk about these different formats. So how well do the different methods of glucose monitoring predict transition to stage 3? Because really, in order to be useful, you really need to be able to catch kids before they get to stage 3 to identify for intervention, etc. And what are the criteria for each method? And then also I'll briefly touch on risk scores. So what we're really trying to do here is to catch abnormalities before they happen. And I think to understand the qualities of the different measures, it's important to recognize that one of the first things that is lost as beta cell mass is lost is the first phase insulin response. So that insulin response initially in response to carbohydrate load. And studies that have been done in the past using IV glucose tolerance tests have shown that this can be decreased, that first phase insulin response, as early as 4 to 6 years before stage 3, but there's accelerated loss over the 1.5 to 2 years prior to diagnosis. And so what we're really looking for is identifying this phase through glycemic measures. So, some observations from the DPT-1 regarding oral glucose tolerance test is that 2 years before stage 3, you can see increased glucose levels. Early C-peptide response is already decreasing, and late C-peptide response is increasing. And that seems a little paradoxical, but basically what's happening is the peak in C-peptide response delays as people progress to stage 3. And then the average glucose levels are known to increase over progression, but there's a lot of changes between states of glycemia within individuals. And there's been studies that have shown that it's not infrequent that people progress from impaired glucose tolerance to normal glucose tolerance, and again to impaired glucose tolerance as they progress to stage 3. So that doesn't appear to be driven by changes in beta cell function so much as changes perhaps in insulin sensitivity. So another way to get at rather than just using the glucose from oral glucose tolerance test is also use C-peptide. And this is not so much used clinically, but has been used quite a bit by TrialNet in identification of people who are eligible for trials. There's the DPTRS, which uses C-peptide, glucose and C-peptide from the oral glucose tolerance test, as well as age and log of BMI. And that can be very predictive. Here on the right, you see from 2 different studies using different levels of DPTRS at baseline, the 2-year risk estimate of progression to stage 3. And so it's a quite robust measure that has been used and shown to be very helpful. I also like to point out the DPTRS 60 because it only requires 2 time points and is just as accurate. So I think this has a lot of potential benefit. This was a paper by Dr. Simmons and TrialNet looking at a more selected data from the OGTT. The only problem with the OGTT, or maybe not the only, but one of the main problems is that the adherence is not great. So of the first 100 children diagnosed in TEDdy with a median diagnosis age of 2.3 years, for those greater than 3 years of age, 30% were diagnosed by OGTT, and the rest were diagnosed either by serum glucose, fingerstick glucose, or A1C. Those who were less than 3 years old, only 6% were diagnosed with OGTT, really speaking to how difficult it is to use that modality for young children. Overall in TEDdy, across age groups, the overall adherence was 62%, with interestingly first-degree relatives being less adherent, or parents who were less accurate in their perception of risk. So it is not really going to be the main way that we diagnose people as progressing to stage 3. So, and as mentioned, the dysglycemia on its own can be variable from day to day. So while it's highly predictive, especially if you use C-peptide into the risk scores, it's not necessarily the most clinically useful for the whole population. A1C is a very attractive measure. So this is kind of an older figure from a paper from 2006, but these are kids from DAISY. And you can see their A1C across age. The red arrow indicates when they were diagnosed with stage 3. But you can see there's a lot of heterogeneity. So there's some kids who just steadily progress with rising A1C as they get closer to stage 3. And then you have others who are pretty precipitous, where there's some vague increase and then suddenly at time of diagnosis a really precipitous increase. So it can be helpful. Some more data on A1C for prediction. So as early as 5 years before diagnosis, it can be useful, especially in the 6 months prior to diagnosis. A paper in 2012 combining data from various studies showed that while the specificity is great, both in identifying impaired glucose tolerance or a stage 2, as well as identifying stage 3 with those cutoffs that you'd recognize from the ADA criteria, the sensitivity is quite low and it's variable. So you need specificity up into the 90%, but the sensitivity is at best 30 to 40%. And that can be worse in the youngest children whose progression might be quite quick. There's another paper from the Finns, the DIP study, showing that a 10% increase in A1C, so not the absolute level, but the increase measured 3 to 12 months apart, showed if you had 10% or more increase, there was a hazard ratio of 5.7 with a median progression to stage 3 over 1.1 years. So the increase itself can be useful. And then for those who had 2 consecutive A1Cs over 5.9, in that study, they showed median time to diagnosis of less than a year. And we've seen similar results in the ASK study. So A1C, the major advantage is accessible for immediate clinical use, and you can see changes over time, but issues of sensitivity persist, and this is especially relevant for the youngest children, who incidentally are also the ones that are the least likely to do oral glucose tolerance testing. So depending on the frequency of measurement, you can miss an acute change, but I think there's some role for the measure of change, the 10% change. And then this was a graph from a really nice review done by Rita Viola and her group in 2016. And I just think this is something to keep in mind when we're thinking about using these different measures in terms of where you catch people. So on the scale of 6 years before stage 3 and stage 3, the last thing to change is the fasting plasma glucose. So while fasting plasma glucose is used a lot for type 2 diabetes, it's less useful for type 1. And then on the range of 1.5 years ahead, you start to see changes in random plasma glucose and 2-hour plasma glucose from OGTT, and the A1C is on the same scale. More recently, there's been a lot of interest in the use of CGM for prediction of progression to stage 3. My colleague Andrea Steck published the first paper using CGM from DAISY, and this is one of our more recent papers looking at data from the ASK participants. For the children who are persistently, this is supposed to say islet autoantibody positive, you can see that if you use, so there's a lot more detail to the different measures of CGM that are beyond the scope of this talk, but just using a cutoff of 10% time above 140 on the A1C, you can see that there's, so those who had less than 10% time above 140 versus 10% or more time of, 10% or less, and those who had more than 10% time above 140, you see that there's a really clear differentiation between the groups who progressed over the next 1 to 2 years. So this has been a very useful measure and has gotten a lot of traction. So what are the pros and cons of measures for pre-symptomatic T1D? So OGTT has a lot of variability from one day to the next and poor acceptance. It requires IV placement, but it is the gold standard in terms of identifying dysglycemia. A1C is specific, but not very sensitive in children. And it's elevated a little bit later in disease process, and it might miss an evolution that's particularly rapid or acute. And then finger sticks, which we actually use a lot, is not an official criteria, but it is inexpensive, and families can do this at home. It has intermittent adherence. And then CGM is well tolerated. You do have glucose trajectory over time. You get some continuous free living data. It can be worn at home, but it is not part of the official criteria at this time by ADA criteria for stage 2 or stage 3. So I just wanted to briefly go over some work we've been doing more recently. The test protocol, which is now completed, where we looked at 36 participants and randomized them to unblinded versus blinded CGM. So the data that's been published in the literature, and I don't think this gets a lot of discussion, but the data from DAISY and TEDdy and ASK, and as well as the European groups, those are all blinded CGMs. But when you put an unblinded CGM on someone, you are giving them minute-to-minute information about the blood sugar of themselves or their child. And so one of our questions is, how well does that work for people? Does it make them more anxious, et cetera? And that is the subject for another talk. But I just wanted to give a little bit of data that kind of shows how this can be useful. So TESS is now completed, and ESTIS is its child, and this is now a multi-center study. We're collaborating with Children's Mercy, Dr. Griffin and his team at the Pledge study at Sanford Health, and as well as University of Florida. So this is one child who was in the TESS study. And at stage 2, you can see the A1C was normal. The OGTT was impaired. And CGM time above 140 was 22%, so above that cutoff of 10%. And here's what you can kind of see in the summarized data, but the day by day, you can see there's some days with higher or lower numbers. And then 2 months later, when the child was diagnosed with stage 3, based on symptoms and blood sugars above 200, at that point, the A1C was still 6. That kind of speaks to what I was saying about the A1C sometimes missing. It would eventually get above 6.5 if this child continued, but at that point, was not yet in the diagnostic range. And so that's just kind of an example of what you can see. So I'm now going to hand off to Dr. Kurt Griffin, who's going to talk a little bit about monitoring in the medical context as well as pledge.
Hey, good morning, and thank you for the opportunity to join. I appreciate both Briggs and Kimber setting up and taking care of a lot of the background and giving a good introduction here. Very briefly, I've been involved for now 5 years with the Pledge program across the Sanford Health system. Very briefly, we're integrating screening into routine clinical care. The meat of this is really at about 2 years, about 5, and then about, once for the teenagers, we check autoantibodies. And really, what lets us do this on a large scale is automating the invitations, leveraging Epic, leveraging all the existing infrastructure in the clinics, the labs, the EHR on down the line. This is in the context of a health system that spreads over a lot of really large rural areas, and yet we've had a really remarkably good uptake and penetration with more than 15,000 people signing up. And once we find the kids who have the antibodies, then we have to figure out, okay, how do we keep an eye on them? And I think Kimber really highlighted why that's so important. So out of all this, we do have almost 7,000 kids with genetic risk scores that we're looking on the back end. I think Jennifer Law will be talking about that a little bit, that approach a little bit later. As part of our screening, we do look at celiac, and we actually have 66 kids that we found that have celiac disease. As we come back to the type 1 diabetes, we had a total of about 263 who had positive screens, 101 of which have confirmed. Some of this was at the beginning, we had pretty sensitive thresholds, and if we go back and apply thresholds that we've kind of settled on more recently, we still have probably about a third of the kids who have initial very low level antibody that doesn't persist when it comes back. And that comes back to the notion of that persistence of that first antibody or first antibodies really is the threshold that opens the door. That's where we really need to kind of keep an eye on things. Big picture from Pledge, we have 67 ongoing metabolic monitoring, and I'll go through that in just a minute here. And we've had 6 who have actually progressed to clinical care for hyperglycemia. Fortunately, none of them have had DKA. And again, I think that reflects some of what we already heard about how monitoring can really cut that rate of DKA at diagnosis. So the monitoring approach, this is kind of the flow diagram that we use for Pledge. It is a pretty close approximation of what's published in the consensus guidelines. And I believe in the chat, there's a link directly to those guidelines. All right, so really, again, any initial positive screen that's a one-off needs to be confirmed. And if they're not persistent, again, some of that is not even just where you draw the line on the assay. Some of that's immunology. And we all have a few cells that are autoreactive. We all have a few low-level autoantibodies if you could actually look closely enough. But our immune system is supposed to keep that in check and regulate that autoimmunity and turn it down. And so I think some of the kids who actually have, a detectable autoantibody, and initially by the time you come back on a second sample, and it's important not to just retest the same sample to see this, in that time, the immune system can bring it under control. So that's part of what we're seeing. The kids who don't have persistent autoantibodies, that's something that we think we don't need to follow going forward. We don't have a lot of evidence behind a lot of the decisions that we're making here, but this is kind of where most of us think is a reasonable way to go forward. For kids who have a single autoantibody, we start out just by saying, okay, you have one autoantibody. Let's retest you because you're not really at stage 1 until you get that second antibody. As we started hearing more data coming out of the Barbara Davis group from ASC about the high affinity single autoantibodies, these are the antibodies that are not just lighting up a positive signal on the radio binding assay, but also show up on the ECL, the electroluminescent assay. That's a little more stringent in terms of its affinity requirements. So the ASC program has been seeing that those kids that have the high affinity singles probably have an intermediate risk, somewhere between having what we usually think of for the single autoantibody and what we see with the 2 or more autoantibodies. And so in light of that, we actually set up where we will keep a closer eye on them and treat them essentially in this monitoring as having 2 or more, keeping on their metabolic status. That's something that is not in the guidance and is kind of still an evolving area as to just how important are these high affinity autoantibodies, but we want to err on the side of caution. For the kids who only have the single that is low affinity, so it lights up it's positive on radio binding, but not BCL, there we're still sticking to, let's go ahead and periodically recheck, see is a second antibody coming up, has that antibody status changed? As long as they stay in the single low affinity antibody, we kind of stay there. If they are persistently negative, they had a persistent positive before and then they're negative. For pledge, we've kind of set the threshold as about 3 years. And if they stay negative for 3 years, they might not be completely out of the woods, but they're probably at a point where we don't need to continue this aggressive monitoring up front. For the kids who have either the single high affinity antibody or the multiple autoantibodies that put them at stage 1 or stage 2, the differentiation there is where are they metabolically. And so our metabolic program there, metabolic monitoring program, we actually are doing a simplified version of OGTTs in Pledge that mimics more what we can do out in the community. And so we're basically doing close to home, wherever their usual clinic is. Each clinic has a lab. We can dose the glucose load according to weight, and that usually actually works pretty well. And we just get a baseline in a 2-hour. All these clinics are used to doing that every morning with all the expectant mothers, and this is kind of stretching them a little bit to get into the kids, but it's actually worked very well across the whole health system. For some of these families, they also are interested in participating in Diabetes TrialNet. Some of the Diabetes TrialNet people are interested in participating in Pledge because we're offering CGM as part of it that TrialNet has not to this point. So we actually have a number of people who are really enrolled in both, and the two overlap more or less pretty well. So for the kids who are in metabolic monitoring, really that frequency of monitoring is going to be determined by age and what is their glycemic status. So the really young kids, we know progress quickly. And I think we see a hint of that even in the TEDdy data that Briggs was showing, where the young kids have a higher rate of presenting without it being detected at the OGTT. Some of that is obviously it's hard to do an OGTT on the little kids, but also they do tend to progress a little faster. So the really kind of the under 2 group, we're actually doing about every 3 months some sort of measurement here. We keep the OGTTs to about every 6 months. As we get into the 2 to 5 range, we're keeping that about every 6 months for the assessments. For the older kids, we start thinking about, okay, can we spread this out a little bit and maybe only do it once a year? Trying to find that sweet spot between keeping a close enough eye on things that they can be caught before they get sick, versus really, the burden on everyone to do this with great frequency starts to add up when somebody hasn't progressed for a number of years. Along the way, whether they have normal glucose and we'll call them stage 1, or they have impaired glucose in their stage 2, we do try to be sure that everybody's aware of what trials are available. Right now, we don't have anything for stage one. TrialNet is developing something for that. For stage two, there is a commercial study open with baricitinib, and TrialNet is about to launch a study with anti-thymocyte globulin. Both these drugs have shown some ability in stage three new onset to delay loss of insulin production. So now we're trying to see if we can back this up and hopefully, as we did with teplizumab, potentially have a better effect at stage two. I think and then finally, once we have someone that reaches diagnostic criteria, that's where we hand off to clinical care. Where we get a little tricky is if somebody is meeting diagnostic criteria according to ADA, but isn't having symptoms, is already meeting treatment guidelines. This is another area where how and when to start insulin becomes a bit of a question. And I think that's where we've seen the CGM data sometimes point us in the right direction, because we've had some kids who, can really maintain their overnight blood sugars just fine. And it's really when they have a high carb meal that they really spike up quite a bit. And we've actually even started prandial insulin for some of those high carb meals without necessarily doing the full quart basal bolus approach just from the beginning. I think it's already been brought up, the notion that so much of what we know about the upper part and rates of progression is because we've had birth cohort studies like DIP and DAISY and TEDDY and TrialNet screening following kids. So by having all these really large numbers of kids being monitored over time, we've developed a much better understanding of, for your given state, what is your risk going forward? We're not where we want to be yet. We're still trying to personalize things rather than talking about groups. But in that setting, we're so far ahead of where we are with monitoring. This is still very much based a lot on expert opinion, what we think makes sense, and clinical judgment. We still don't have tremendous amounts of data to really justify what is the right frequency of testing for the kids at stage one versus stage two, or a 3-year-old versus an 8-year-old. Hopefully, as if we have kids in more of a research setting doing this, we can collect more of that information. At the same time, this is now becoming part of clinical medicine, where there are a lot of places that have early stage clinics and are providing this kind of monitoring in a clinical setting. I do want to close out with one comment about CGM. I think it's going to be very helpful. As I said, we use it. It's very helpful in terms of guiding how and when to start insulin for some of our kids. In terms of detecting and staging where somebody is, I think there are a lot of technical artifacts that we've seen pop up periodically, including we'll get like a month or two where a whole bunch of them just have an elevated baseline. And I think applying the published cutoffs without having some pretty rigorous quality control and assessing, does this really meet criteria that we could put into that pipeline, runs the risk of overcalling a lot of these things. And I think that's another place where being able to pull the data and look at what are the patterns we see, how can we automate and come up with a consistent way to do that QC check before we go ahead and just turn the crank on algorithm. And so with that, I want to thank everybody that's participated in the trials, because without them, we would never make any progress on this. The pledge team really, for as big as it is, really run by 3 people that are sitting in Sioux Falls. And I want to thank the Helmsley Charitable Trust and Sanford for their funding in this. And with that, I think it's time to pass off to Dr. Jennifer Law.
All right, thank you. Pull my slides up. Well, thank you so much for the introduction and just this discussion already about how to monitor we're going to take a step back and look more at who should be monitored based on our experience trying to monitor individuals identified in a pilot newborn screening program. So Early Check is an optional newborn screening program using genome sequencing to screen newborns for both monogenic conditions as well as type 1 diabetes, utilizing the blood spot at the North Carolina State Laboratory for infants under 1 month of age whose parents opt into this program. And so what we've done is we've calculated genetic risk scores for their lifetime risk of developing type 1 diabetes in just over 5,000 babies. And we categorize the risks into low, moderate, and higher concern categories based on their lifetime risk. Results were then reported to families through a portal, as well as letters sent to the address that we have on record. You can see that in the portal, along with the result itself, there is a link for signing up to discuss results with a genetic counselor. There's a video explaining type 1 diabetes and how early check screening was done. There are fact sheets and a follow-up timeline. And as you were to scroll down on the report, recommendations are given, including, what should parents do? And so knowing the signs of type 1 diabetes, recommendation to schedule a time to talk with the genetic counselor. This is all free of charge. We encourage parents to schedule antibody screening if the baby was determined to be at high risk, and encourage the parents to talk to their doctor if signs or symptoms of type 1 diabetes occur. So in looking at our caregiver follow through on these recommendations, we see that of the babies with a low lifetime risk for type 1 diabetes, approximately 64% viewed their results in the portal, and about 19% downloaded the report. As the risk for type 1 diabetes increased, the more parents and caregivers viewed the result in the portal and downloaded it. This is a graphic that we used to illustrate for parents what the signs and symptoms of type 1 diabetes can be. And we had genetic counselors who would talk to the parents about these symptoms and describe these symptoms to the families. Some common questions during those discussions with genetic counselors included when to look out for the symptoms, the earliest age at presentation, and what do the symptoms actually look like. Most parents found the graphic included in the screening report to be helpful. When it comes to actually, who attended genetic counseling sessions, you can see that of those who had a low lifetime risk, only one parent signed up for genetic counseling. Only 3% of those with a 2 to 5% lifetime risk for developing type 1 diabetes, but almost half of parents in the higher risk categories attended genetic counseling sessions. So we were encouraged by that group of folks actually engaging in genetic counseling. So those who had higher risk genetic risk scores, they were encouraged to get autoantibody testing starting at 9 months of age, and about half of infants were screened for antibodies. 3 individuals did screen positive with a single antibody, and on recheck of those 3 babies at 12 months, none of them were positive. Autoantibody testing was also available at 24 months of age for infants in both the moderate and higher risk categories. Here you can see the results for those with the higher lifetime risk. Again, about half attempted antibody screening. One infant tested positive with a single antibody. That infant had tested positive at 9 months of age. It had disappeared at 12 months of age, but then returned at 24 months of age. That infant did present with clinical hyperglycemia and type 1 diabetes prior to the 27-month confirmatory testing. That mother did report that she pushed for blood glucose testing when he had presented with flu-like symptoms because she was aware of his high risk for type 1 diabetes. And so she does credit participation in early check with preventing a worse presentation for her child. For those with moderate lifetime risk, only a quarter of them attempted antibody screening. None of them have had antibodies. The antibodies were tested either through the Barbara Davis Center via a home kit with finger stick and capillary blood draw, or through LabCorp with standard phlebotomy draw. The home kit was successful about 2/3 of the time, while the phlebotomy draw was successful about 80% of the time. If a sample was unsuccessfully collected, the families were offered the opportunity to try again. Of those who tried again, only 2 were unsuccessful on the second attempt, while 4 declined a second attempt. When it comes to the recommendation to share early check results with a child's medical provider, the staff relied on the parents to make this communication. While early check staff heard very little from participants' pediatricians, I can tell you that anecdotally, my colleagues at UNC did get some phone calls from providers asking for more information. About half of parents reported that they shared those results with their baby's doctor. Some said that they called their pediatrician immediately. Others waited until a well-check visit. Parents who did not share the results reported they either just did not want to or they forgot to. Now, shifting to the parent perspectives of this study. So surveys were sent out to parents of infants with moderate or high risk at 10 months of age, and interviews were offered to those individuals at 11 months of age. Surveys examined parents' understanding of results, their feelings and utility of the results, their attitudes about participating in decision regret. Interviews address the same concepts as survey measures, plus some additional topics, including attitudes about educational materials and perceived acceptability and follow through with surveillance and management recommendations. Here you can see demographic comparisons of survey respondents and interviewees compared to those in the moderate and higher risk categories. Respondents and interviewees were slightly older, and more of them were white and reported higher education compared to the overall moderate and higher risk individuals. When parents were asked their motivation for enrolling in the early check program to begin with, 21 indicated knowledge is power. 11 felt that there was a minimum burden to participation. 5 wanted to contribute to research, and 4 had a family history of type 1 diabetes. We were pleased that half of parents indicated they understood their child's test result extremely well, and a third understood it quite a bit, while very few indicated a little bit or not at all. Interviewees consistently mentioned the report design was clear and accessible. They appreciated the graphics, the plain language, and opportunity to speak with a genetic counselor. There was some confusion around how GRS was calculated and some confusion about what this means for their child's future health. A Likert scale was used to examine the perceived utility of results, with 1 being not useful and 7 being extremely useful. Parents indicated the results helped them to understand their child's health, that they were able to help the medical community, and that the results helped them to feel more in control of their child's health. From the interviews, parents described a sense of preparedness, and they would like more involvement of their pediatrician and continued guidance. When examining feelings about the results, parents scored quite well overall. You can see the great majority were not upset, only a little anxious, not uncertain, and they felt that the testing was helpful. The attitude scale showed that parents generally reported participation in early check to be reassuring, a good thing, important, and beneficial. Most parents indicated in interview that they would participate again if they had the opportunity. They found the resources and study support to be helpful. Some had hope for a diagnostic yes or no rather than a risk range, and there was some stress related to follow-up blood draws. Now, looking at decision regret scale, most parents reported no regret. About a quarter reported mild regret, and about 7% reported high regret. I think that these quotes from the interviews are helpful. One interviewee stated, it's been helpful. I feel like having various check-ins, like the questionnaire, and then the meeting with the genetic counselor, and then the retest. I feel like you have maintained communication with me regarding her results, so I feel like continuing. Another stated, I'd still do it again. I'm still glad we got the information, but it's like there's always that piece of not knowing what's going to happen. While another interviewee stated, but yeah, as far as the diabetes screening thing, it was, a lot of blood, sweat, and tears that went into that process. So kind of being left at this point with the uncertainty makes it hard to say if we would do that part again. So in conclusion, parental perceptions of the screening results were generally positive. Parents require educational support to understand the screening process and results. And while parents expressed a sense of preparedness, they still felt unsure about their child's future. And parents desire primary care engagement and continued support. And that's it for me.
Great. So I think we can open things up for questions. Oh, Kurt.
Hi, yeah. So I really appreciate how these different pieces are fitting together. I want to kick off, one of the challenges, because that's part of the title of this session here, So Kimber's presentation showed kind of the stretch of progression and include, okay, by the time you're at stage 3, we could argue stage 2, at what point do you transition to specialist care, you're seeing peds endo, et cetera. But that means that at some point more of this is going to fall on the primary care people. And what we've just heard from Jennifer, and it matches what we've seen in Pledge, is the people, the providers that the families have a relationship with and who they go to are going to be the primary care providers, pediatricians, family medicine, whoever's seeing them. And yet there's this gap of they don't necessarily have a lot of depth on how to do a lot of this. And so I guess, I know I'll just share from the Pledge standpoint, we've tried to get in front of everybody. We try to have toolkits for them. I know there are other people working on trying to develop some materials, but I was curious, what other approaches have people found useful to help those primary care providers kind of get up to speed and play a little more of an active role and not just get caught like deer in headlights?
Yeah, I think that's Kimber, maybe a good question for you because of Ask the Experts working on that specific topic.
Yes, I can give you an answer, although it's probably not going to be fully satisfying. And talking with the pediatricians I've worked with would probably be more helpful than me saying how it's went. But basically, the program we have is when there's an antibody positive patient and they don't have somewhere to be plugged into, we try to work with their primary care provider or an endocrinologist, depending on kind of how dysglycemic they are, and get them plugged in. And we've also tried some larger scale, like mini fellowship programs that have been pretty difficult to implement, actually. The most effective way, which is not which is hard, is a one-on-one interaction with somebody and kind of like walking through a patient case, and then I feel like it spreads from there. It's a little bit of a grassroots effort, but I think we all want to have this big program or whatever we can do where everyone's just going to be educated and then do everything. But until there's more experience among pediatricians, I think we're going to have to continue to just kind of help people one-on-one as much as we can.
Yeah, and to speak to that as well, I only alluded it just kind of in passing, the ESTIS program, the early stage T1D education and support. So we're hopefully we've recruited from locally and hopefully are starting to recruit from the Pledge participants, I think sometime in the next couple of weeks. But the idea behind that is to try to bridge this gap where we are right now, where you need case management of people who are at risk, but a lot of people who are out there who don't really need specialty care yet, but still need to be engaged, and also some amount of monitoring. So what we have is a platform where we can upload CGM or fingerstick data, and we have like a case board of what is their percent time above 140 and what's the last time they've worn a CGM, with the goal, and everybody who participates has to have a local. So right now they're the study sites, right? But has to be have a local pediatrician who ideally would get integrated with one of the education setups that Dr. Simmons has going, so that they know what it is that we're talking about, but that this platform helps monitor people when your general pediatrician isn't going to know, like, how frequently am I putting on a CGM? What do I do with it? And now what? And then we also on that platform have online education and some group education sessions, so that, because I think part of it, and Jennifer kind of got to this, is people feeling like they're not given information and then just sort of tossed to the wolves, like, okay, now what do you do with this? Good luck, right? So you need to have some kind of support and education so people can have their questions answered.
Thanks, Brigitte. I wonder also is there a link for that program, for the ESTIS program, that we could drop into the chat if people are interested in reading a little more about it? And also I have a few questions from the chat. Constantine asks, I think this one's about genetics. I presume that the WGS newborn screening is general population based. How is the percent risk for T1D determined? I presume that GRS2 is used. It gives a score, but how is the percent calculated? And what do you do with non-European ancestry?
Yeah, that is a great question, and one that I'm going to have to get back to you partially on. We did use the GRS2. I can tell you that so we use self-identified race, but then we also looked at genetic ancestry. And it performed well across most demographics except for those who were of African ancestry and the self-identified Black ethnicity. So it even like the Hispanic and the Asian population seem to perform pretty well with that GRS2 score. And we are looking at how can we improve this, looking at other population data. As for how did we extrapolate the GRS2 score to lifetime risk, that is something that is a little bit above my head, and I'm going to have to, I can maybe send you an email with follow-up for that.
Thanks. It looks like we have a couple questions about CGM data. One from Monica says, Kurt, great presentation. What's the timeline for pooling the CGM data and potentially then using the outcome to inform standard of care?
Yeah, I think again, Andrea Steck and the group in Denver have already done a great job as far as starting that. In terms of pooling things, that's something that a number of us have talked about. I was on a different call yesterday with somebody else. It just takes time and a little bit of support and carving out and building the infrastructure for that. So the short answer is I don't have a timeline. It's something that I think as we're getting more information becomes more important. So we will get there, just don't know when.
So to follow up on that, Kurt, are you seeing or is there an evolution of using the CGM data away from population those cutoffs of time above 140 to longitudinally following an individual and their changes, just like how Brigitte referred to that change in hemoglobin A1C over time being significant, whereas if you're looking at more of a population, you won't find a difference.
I think the number of people who have had longitudinal CGMs is still small, but it's growing quickly. In my experience, as I look at the ones that we've had 3 and 4 serial CGMs, I think just the noise in the measurements, it makes it hard to really say, like the A1C, I think is a pretty robust, it's pretty clean. But here, there's so much day-to-day variation in insulin sensitivity, as Briggs brought up. It's that trying to go from that rapid minute-to-minute thing into something that you can say, here's a clean sample, here's a threshold. I think we're not there yet.
I think we're definitely getting better at handling ways to analyze that data, though, aren't we?
Yeah, no, that's something. So in terms of combining data, we've had a paper that came out, I think it was last year, looking at with the Jaeb Center, and it was our data plus the FINS plus some TrialNet, and looking at CGM. And we have some more kind of looking at like the CGM versus OGTT is another thing because you're not always getting that data in the same people. So we have something we're working on to get that out. So I think there's a lot of interest in trying to combine our approaches. Somebody asked earlier on about the unblinded CGM anxiety around hyperglycemia and variable blood sugars. So yeah, that is something that was kind of one of the big questions for tests, just kind of being aware that as we're moving into more clinical interest and acceptance of early screening and monitoring, that you have to think about like these things that we've done in research with the infrastructure of research. If you just suddenly spring those on the general population, what happens? Sort of not yet published, but sort of the families that are using unblinded, we're not just putting it on and setting them free. We, as long as you're giving people information about what they're looking at, how to recognize, so, false lows that wake you up at night, what to do about that. There's a lot of practicality to using it in somebody who's pre-stage 3, just because they're not really designed for that purpose. But in that context, people have really liked them. And in fact, the majority of families chose to continue using it unblinded after, all but one chose to use it unblinded after that unblinded intervention. So I think it's a matter of giving people support, education, and structure around it, and not just plopping it on somebody and sending them on their way, because that is actually very stressful. So we had an inadvertent pilot where for a brief amount of time we couldn't get blinded CGMs, and we realized that it generated a lot of questions.
That's interesting. Matthias, do you want to unmute and ask or tell us your comment?
To be very brief, because I have to go on another call, but I only have a short comment about this earlier mentioning that the first phase insulin response is lost by immune activity. I don't think we know these things for sure. I don't think what we see pathologically is something that is consistent with a strong autoimmune disease, especially in the early stages. I just wanted to bring that up. I wrote it in the comment, and it has certain therapeutic consequences, I would argue. But that was the only comment. Anyways, it was very informative talk.
Yeah. Well, thanks. I think we're going a couple minutes over. Thank you to all the panelists. That was a very informative and interesting talk. And we'll have this processed and up onto our YouTube site shortly for any of you to share. I think it's going to be a great resource for people that have had screening done and may have questions about it. Also for other healthcare providers that I know you have the Ask the Expert program, but this will be a source that an additional resource that is available for everyone. So thank you very much.